Okay, so we're going to look at male and female reproductive system, and then some growth and development in part 3. Um, so I could not get the material to post on Canvas, so I emailed. Okay, um, so males and females have these things called gonads. Okay, they're considered the primary sex organs. In the female, they are called ovaries, and in the male, they are called testes. Okay, the gametes in women are the oocytes, and in men is a sperm. Okay, and there are different ways the body will transport these gametes, whether it's the oocytes or the sperms, from the gonads to the fertilization site. Okay, so primary sex glands or sex organs in the female are the ovaries. Okay, the accessories would be the uterine tubes, the uterus, vagina, clitoris, and mammary glands. Okay, the view here of uh, some parts I do would like for you to know. The uterus. Okay, basically that area there. The broad ligament, the ovaries. Okay, the fimbriae. The uterine tube, also known as the fallopian tube. Okay, so uterine tube or fallopian tube. And that's also where an ectopic pregnancy, or if you have an ectopic pregnancy, that means the egg is developing in the fallopian tube or uterine tube. Okay, anywhere in there, which unfortunately will have to lead to a removal of the fallopian tube, as that is and can be life-threatening. Okay, so in my office we do lab testing, blood chemistry, and all that. Another one is pregnancy tests. So probably wondering, like, why the heck would you be doing pregnancy tests? Well, if you look at the abdomen, okay, so there's the belly button, right? Diaphragm would be like up here, right? So then the legs. You can divide the abdomen into quadrants, right? And so in the lower right quadrant, right, you've got a bunch of stuff. You've got the appendix that's down here, ovaries, fallopian tube. Okay, you also have kidneys in here that can send referred pain down to lower right quadrant, down to the groin. Okay, so it's not unusual for me to have patients that come in with lower right quadrant pain. Okay, it can certainly be lower left quadrant as well, but the lower right quadrant seems to be more dominant with pain compared to the left, at least in my experience. You also have the ileocecal valve that's in the lower right quadrant area. So we have a lot of stuff, right? So we'll come in holding the, they kind of hold the that lower right quadrant area because it's tender, it's painful. You can see that there's a little bit of an altered and guarded gait, right? So we get into the history, you know. They're like, well, they say, well, I think I pulled a muscle, or I was doing box jumps, I was doing CrossFit, I was running, I was doing whatever. Okay, or just something else, something that would cause lower right quadrant pain. So, dive into history, and I'm like, okay, so we try to rule in or out appendicitis, right? Muscle pulls, kidney issues. Then you ask questions, okay? Uh, any chance of pregnancy? And sometimes they'll look at you, yeah, why? Okay, and then you explain this stuff, right? That, the ovaries and fallopian tube and all that's located in that area. History of ovarian cysts, right? Polycystic ovarian cyst stuff. And maybe the answer is yes. Okay, so it could be dealing with that. And maybe even a herniation, right? So herniations can happen in that area, inguinal hernias. Okay, so you do your palpation exam, and it's pretty easy to palpate if there's something going on in here. It's pretty easy to palpate for local tenderness. Okay, and you can get right over the appendix, over the iliopsoas muscle that's deep in there, right? One of your hip flexors. Um, there's some tests you can do on kidney, tests you can do on ileocecal valve, and all that stuff. Okay, so you can start ruling things in, ruling things out. Well, that's why we have the pregnancy strips, so they can basically pee on the stick to see if, typically it's something like this. The stripes are like that. And if you get a red stripe that shows up that kind of makes a cross pattern, that would be a positive finding because it's looking for HCG, right? Human chorionic gonadotropin, which is only present if there's a placenta. So that's why. Okay, so no, I don't do like specialize in pregnancy and labor and delivery and all that, but we certainly can help. And quick version of that is, one, if we happen to get a situation where that might be a thing, yeah, we'll have them, pee on a stick, and very simple. It's either positive or negative. And then if it's not that, then we can treat ileocecal valve pulled muscles. If it's kidney, then we do a urine analysis looking for blood in the urine, um, you know, white blood cells, proteins, whatever. Then that's kidney infection, or perhaps you're flirting with kidney infection, and so on. So that's why. And then also the way we can help is if a person comes in pregnant, and I do have at any given time, I always have several, pregnant moms that come in, and we talk about nutrition. We talk about, just how to have a successful pregnancy through basically diet and lifestyle. Okay. What it looks like to, basically eat for two people, the nutrition, things that you can do to strengthen the pelvic floor to prepare for delivery. So we get into all that. So I do have a certain role that I can play with this. And it typically has to do with strengthening and nutrition and lifestyle, trying to avoid toxic things and so on. Okay. Also, we check for what we call uterine centering. So during pregnancy, you want the uterus and all that to be as centered as possible. What happens is sometimes it will get off-centered, right? So you have, maybe something like this where it's shifted to the right or shifted to the left. And the reason why is because the ligaments and the wall of the body that it attaches to gets too tight. Okay. And so there's a lot of things that go into that, the hip flexor, so the iliopsoas is just, let's say, chronically tight on the right side or chronically tight on the left. That will contribute to off-centering all this. Okay. You also have the suspensory ligament that you check, and then the round ligament, which this isn't showing that. But so, you just palpate. You get in there and you can feel, and of course, the mom-to-be can feel it. Like as soon as you press on the tender spot, they go, "Oh, that's right where it hurts when I walk," or whatever. And then there's a lot of cool soft tissue things that you can do to loosen either the tight right side or the tight left side up to get everything recentered. Okay. Then you show them how to do that at home. So you lay on your back, you bend your knees up, and there's a certain way you palpate yourself and different things you feel for to try to keep things as centered as possible. And then what that does down the road is it helps for when the baby's ready to turn, okay, for delivery. Usually gives, more room and less chance of error for that stuff, okay, and so on. So there's some really cool things that, one can do that we'll just say is non-medical, right? So more in the lifestyle, PT, exercise, strengthening, preparing, different stretches, some really cool things. Also have a pregnancy pillow. So as you can imagine, especially once you get to the third trimester, uh, it's hard to lay on your tummy. So I've got this pregnancy pillow that has cutouts so that the mom-to-be can lay on her tummy, and they love it. And as soon as they lay down, you get this, oh my goodness, it feels so good to lay on my tummy again. Okay, and we start doing work on the hips and low back and, different areas that support the pelvic floor and so on. So some really neat things that can be done on the therapy side of things. So that's where, these broad ligaments and suspensory ligaments, being able to look at the quadrants and see, kind of visualize what's going on inside of a person as you're palpating around, doing your exams. Okay. Okay, the ovaries are surrounded by the epithelial, so one cell layer thin of your cuboidal cells, so simple cuboidal epithelium, called the germinal epithelium. Okay, and then cross section inside. So a follicle is basically like a fluid-filled sac, if you will. So it's like a cavity, an area for something to grow and develop, right? So this would be looking at a mature follicle here, and you can see the egg or the oocyte in there. And then at some point, as this follicle continues to mature, it will work its way closer to the end and release the egg. Okay, so what helps with that is follicle stimulating hormone, right? Released from the pituitary. The anterior pituitary releases follicle stimulating hormone, which would go to the ovary area to help communicate with that from a hormone perspective. Okay, so the oocyte is surrounded by the follicle. Okay, and it does start out small. Okay, so your primary follicles do start out very small, And then as they cycle around, it will enlarge. Okay. Now, from a PT, sports medicine, therapy standpoint, what we have found is that I was trying to find a, a better anatomy chart here. Okay, but if you can visualize behind this area, you have the iliopsoas muscle. Okay, so a hip flexor. Okay, and so it runs behind, it's like basically posterior to these structures here. Now what happens is so a couple things, and I'm just going to piggyback on the ovarian cyst stuff because it is a problem, and it isn't, meaning across the land for women, it can be an issue. Okay, and it's very uncomfortable, it's painful, it can actually lead to a lot of problems. Okay, so one is how active the person is. Okay, there is such a thing as overactive. You're too active, you run too much, there's too much training, there's too much hardcore things involved. Okay, um, and so like think about like a soccer player, especially one that's trying to get like a college scholarship, they play in college. I mean, if you think of how hard they work and how long they run, you know, the hours and hours of training per week for basically their whole life, right? And so what happens is that iliopsoas muscle starts to, adhesions start to get created. All right, so you start to get adhesions in this area. And so what we look for is we look for those adhesions. You know, you can get in there and palpate for the muscle. You can tell if this area basically needs to be unstuck from the psoas. Okay, and that's doable, right? It's very doable. Now, once this happens, you know, then it's almost for them, it's like this miracle thing. It's like, whoa, okay, you know, I'm not getting that pain anymore, my monthly cycles, and throughout that whole year, you know, chronic reoccurring polycystic stuff, like pretty much gone. All right. So that helps them tremendously. And then there's things they can do to maintain that at home. So that's one thing, you know, for you all to just keep in the back of your mind if you're working with athletes, especially youth athletes. And there's, you know, the chronic reoccurring, look for adhesions because of overtraining from the muscle to the structures of the, like the lateral uterus part here, okay, the ligaments and all that. It helps tremendously. Another one is too much estrogen. Okay, this is very common. Both men and women get bombarded with too much estrogen in our just in our culture, and it has to do from, you know, diet, things found in city water, tap water. Just a lot of things tend to have estrogen-like things in them, things that mimic estrogen, your Zen estrogens. Medications have a lot of estrogen in them. So the body's constantly being bombarded with estrogen. So the estrogen progesterone ratios are way off. Okay. So too much estrogen and usually not enough progesterone. And that also contributes. So once, you know, if I get a female patient that has chronic reoccurring problems with ovarian cysts and all that, these are the things we're diving into. Looking for adhesions, looking for iliopsoas stuff, analyzing the estrogen, progesterone, and then trying to balance all that out. Now, in time, that does help. Okay, it helps tremendously. Typically, the medical version is just to prescribe estrogen, sometimes progesterone, depends on the case, but they don't tend to look for adhesions and other things like that. Okay. Um, okay, so the different stages of development for the follicles. Now, keep in mind as you're visualizing this, right? So I'm going to start here and it kind of ends this way. Um, the ovaries do need room, like breathing room. Okay, they just need some breathing room to be able to do this. So that's why if things are too tight, you're can kind of look at it as you're squeezing on this, just not allowing for this natural flow to take place. So the body has to work too hard, and that's where some of the cyst stuff can come from. Okay, so it's actually a really easy fix. Just some stretches and some other therapies, and it's great. Okay, but on this one, I just want you to know that you have the primary follicle. Okay, that leads to the secondary follicle. Okay, that eventually can lead to the release of the egg. All right, we're going to get through some of this. Give me one sec. Okay, so keep in mind the androgen hormones are estrogen, progesterone, testosterone. Okay, so the adrenal glands do release these, right? Your estrogen, progesterone, testosterone. Okay, so both genders have these because of that, but also the the ovaries will release progesterone and estrogen in women, and the testes, testosterone in men. So as far as ratios and the amount, men tend to have more testosterone, and women tend to have more estrogen, progesterone. Okay, so the corpus luteum secretes the progesterone and the estrogen, which helps stimulate the growth of the uterine endometrium. Okay, now here's another clinical thing to, that I work with, or we should talk about, and that is the thickness of the uterine lining. Okay, so down the road at some point, women may be thinking about pregnancy, and you want the uterine lining to be at a minimum of 6 millimeters in thickness to about 14 millimeters in thickness. Okay, the thicker the lining, the better, and that's because it allows for the egg to actually implant itself in the thickness of that uterine lining. Okay, so what um, as we get patients that uh, have fertility issues, okay, and yeah, you're probably thinking like, why the heck would a fertility go to see you? Well, they're doing the medical dance. They've been to fertility clinics and they get tested for all sorts of everything. I mean, there's so many things that they look for. Okay, they do all the hormones. They look for the fallopian tube to see if things are able to travel down the tube. They look at everything. Okay, but what happens is from a functional medicine standpoint, there are things that we can work on to try to go from, like some come in with a 3 millimeter thickness uterine wall, and we're trying to get it back to somewhere between 6 and 14. Okay. So that one's complicated to talk about just through this lecture right here, because it's very involved. But the quick version is you're assisting in changes in hormone levels because the progesterone and the estrogen help stimulate the growth of the uterine lining. But keep in mind, most people have too much of this, too much estrogen, and not enough progesterone. So as time goes by, there's changes in the thickness of the wall. So one of them is trying to get estrogen and progesterone balanced. And so what we do with on the functional medicine side is analyze what they're doing that's promoting too much estrogens, another thing called Zen estrogens, okay, and other things that mimic estrogens in the body that are binding to the receptors, creating offset ratios. Okay, so that's the stuff we start tapping into, and it does help. Okay, it can help tremendously. Okay, so um, all right, so the uterine tubes, also known as the fallopian tubes, and this is the term I tend to use the most. Okay, they do extend from both sides of the uterus. You're only seeing one side here. There is another one on this side, and it is designed to allow the egg to travel um, down into the uterus. And you have cilia that's inside of the fallopian tube. Okay, the cilia are little hair-like projections that are designed to move the egg in a certain direction, toward the uterine wall. Now, sometimes the cilia is damaged or it's not working right. Okay, so that's one area that can contribute to the egg being implanting itself on the fallopian tube wall, and growth and development starts there, which is dangerous. Okay. So different things can cause the cilia to not work. A lot of it has to do with just some poor lifestyle things, including smoking. Okay, things that just slow down or damage the cilia in the body. Okay, kind of bottom line, lots of inflammation. Um, okay, um, the wall of the uterus is made of 3 layers. The mucosal layer. Okay, so a lot of layers, tubes and the spaces in our body do need a mucosal layer, right? Your esophagus, your trachea, large intestine, small intestine, and so on. Really, all the tubes and the different uh, um, cavities in the body need a mucosal layer. Okay, it's a protective lining. You also have the muscularis layer. Okay, and this is actually a very strong muscle. It does respond very well to oxytocin to help with contraction. And the outer serosal layer. Okay, another 4 parts to the uterus. We have the fundus. Okay, the body, and then um, the isthmus and the cervix. Okay, fundus, body, cervix, and the isthmus. Okay, and there's that round ligament I was mentioning earlier. Okay, part of the broad, embedded within the broad ligament. And these ligaments, because they attach to the wall of your body, can get tight, okay? So the tighter your muscles, the more the asymmetries because of right versus left side dominancy and how active everything has been with muscle development. If this gets too tight, yeah, things will shift to one side or the other. Okay, functions of the uterus. It's the site of implantation. Okay, supports and protects the developing embryo, fetus, and then also helps to eject during labor and delivery through the muscle contraction. Okay, and there's actually some videos on that I'll have you all watch later during lab time. Okay, there's some really cool 3D stuff that's out there on how all this works. Okay, here's the endometrium lining the mucosal composed of simple columnar epithelium. Okay, so that's your one cell layer, thin, shaped like a column. Right, there's the nuclei of each one. So your cuboidal would likely be shaped like a cube, and then the squamous would be scale-like, right? So the simple columnar epithelium. Okay, the myometrium is the muscle layer, the smooth muscle layer. And then the perimetrium is the outer serosal layer. Okay, so changes in estrogen and progesterone concentration during monthly cycles. Basically, you have day 1 to day 28 and roughly day 14. So you can break it down by day 1, day 14, day 28. Okay, now this one is also an area I help some patients work with because of hormone related migraines or headaches. Okay, typically it's the migraine, but sometimes they're spared and it's just a headache. Okay, so what happens is the pituitary gland, right, which sits in the sella turcica in the skull. Right, so you have the infundibulum and then the anterior and posterior pituitary. And it sits in this bony thing called the sella turcica, which is part of your sphenoid bone in the skull. Okay, and this releases your follicle stimulating hormone. It also releases luteinizing hormone. Okay, it releases a bunch of stuff, but these two in particular is what we'll focus on. Now, what happens is with the stuff I mentioned earlier with the xenestrogens and the receptor sites possibly being blocked because they're a competitive site by things that mimic estrogens, things that are too tight, tissue that is inflamed, and so forth. The follicle stimulating hormone and luteinizing hormone are not binding to the receptors very well. So the gland goes, no problem, I'll just work harder and release more and release more and release more. So what happens is this gland starts to swell. The pituitary gland starts to swell, and it can only swell so big before it hits the bony surrounding, the sella turcica. Okay, that causes a headache, that causes migraines. Also, above the pituitary gland is your optic chiasm, right? Okay, so the optic chiasm, which is where, if you look at an inferior view, right, you've got the eyeballs, you've got cranial nerve 2, okay, you've got optic chiasm, and then things radiate back to the occipital lobe. right? So right there, the optic chiasm is where this can get affected. So what that does is it blurs vision. So you see the auras, the spots, the whatever, like typical things that can come with migraines. Okay, so I get them and we go through their history and they've tried, like every migraine medication, they've tried this, they've tried that, nothing really seems to be working. So then what we do is we start creating a calendar. Okay, now this is interesting because it does seem that a lot of women don't seem to track their monthly cycles. Now, some do, right? But also some don't. And today there's really cool apps and stuff on your smartphones and so on. Or you can just, do an old school paper calendar and keep track. So if they're already keeping track, then I take a look at it. If they're not keeping track, then we start keeping track. And here's what we're looking for. Okay, now I think you guys will find this very interesting because migraine headaches, because the monthly cycle stuff is annoying, and this can help. So you have I prefer a paper calendar for this. So you have your 30 days, right? Your Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, Saturday. All right. So I'm going to keep this calendar thing very simple here. But let's say um, on day 14, okay, they mark it. There's a cycle. And then on day uh, 28, there was another, the X represents a migraine. Okay, then on day 1, there's a migraine. And then it's predictable. On the next month, day 1, day 14, day 28. Next month, day 1, day 14, day. Now we've got a pattern. We've got a very consistent, distinct pattern. Every time that the body does some pretty uh, sensitive hormone changes, okay, so onset of ovulation, onset of menses, and all that, uh, migraines happen, okay. And so now we can say, all right, this is certainly hormone related. So then we start diving in to help reverse how hard the body has to work so that this pituitary gland, okay, that pituitary gland does not swell so hard and hit the bony surrounding of the sella turcica. So the vision stuff improves, the migraines improve, okay, lots of things improve. It's pretty remarkable. And if people suffer from this stuff, they'll take anything. Meaning if it's constantly a 10 out of 10 in pain and you can knock it down to a 2 out of 10 or a 1 out of 10 or just anything that's down there, it's great. Okay, sometimes a 0 out of 10. So that's based off of a 28-day cycle. Okay. So you have day 1 through 5 from the ovarian, so the follicular phase. Day 6 through 13, also the follicular phase. Day 14 should be ovulation, and day 15 through 28 through the luteal phase. Okay, some of the ones coming in from fertility clinics have, we'll just say like the fertility clinic's version of a calendar. Okay, because they're usually on, different hormones and different medications and things like that. So around day 14, that's when they're supposed to be, we'll just say sexually active to see what happens. Okay. And it's funny because sometimes the husband and the wife are in my room and, we're both, all of us are talking about it. And, usually the wife is like into it, here's what the fertility clinic people, here's our schedule, here's what we're doing. They show me the calendar, show me all the tests, all the stuff they've been through. And then, she'll then look at her husband, honey, it's day 10. You know what that means in about 4 days. And he's over there kind of looking at the ground going, oh my goodness. He goes, why can't this just be more natural? Why does it have to be scheduled? Oh, that's very common to kind of hear that. So, in other words, um, and I've been doing this for over 10 years with people. I've learned to try to tell them just let nature take over. Okay, just have fun with it. Try to let nature take over. Don't always have to go by a calendar, type of thing. But it is kind of funny to see, the two different dynamics there. One that's super excited about going by the calendar, and one that would rather just let nature take over. But at the same time, you also get it, right? They're going through a tough time, and they're spending a lot of time and money doing fertility things and so on. Okay, so this is also why I was trying to share with you some of the things that hopefully you can help, especially during the teen years, because for women, because if you can catch this stuff early, you can likely age into a healthy body, and maybe not worry so much about this down the road. um, I'm in the Cherry Creek School District, so I get a lot of Cherry Creek high school athletes, and also some Heritage, some Arapahoe High School, some Regis as well. And these are just, when people fill out their new patient intake form, we also get into a review of systems. Yes, they might be there for their plantar fasciitis or their headaches or their back pain or whatever. But because we do a review of systems, we're also looking at other things as well. And sometimes we can help those other things and sometimes we can't. Okay, but you still want to do a review of systems. And so, okay, fine. They're there for their knee. They can't really use it. They can't really jump and run right now. But on the review of systems, it does say history of migraines, history of, ovarian cysts, history of stomach pain, history of nausea, vomiting, things like that. So then we talk about it, and perhaps it's an area we can help. Perhaps it's an area we can't, but we still dive in to see if we can help. So catching it early is key, right? Early diagnosis leads to a better prognosis, okay? Which is a whole lot better than, let's say, you're in your late 30s and for the first time trying to turn over a new leaf. Now, listen, it's never too late to turn over a new leaf. Doesn't matter if you're 100. You can always try to turn over a new leaf, and start, doing things more on the health and wellness side of things. Less alcohol, less smoking, eating cleaner, basics of diet and exercise stuff. Like, that's never too late for that. However, the earlier you can catch this and the earlier you can do that, the better. Okay. So I get that opportunity when working with high school athletes because they're still young. So they'll still have, tons and tons of time and a future ahead of them. And also because they're minors, the parents are usually in the room, and we talk. We've even had the talk of sometimes it's a girl, around 12 or so with lower quadrant pain and back pain and just all these headaches and problems. And so they're bringing them in, and, the parents are in there, and we're talking and palpating the stomach area and so forth, and palpating the lumbar spine. And then, I kind of look at the parents, and they're looking at me, and they're like, what? And I'm like, um, have you had that talk with your daughter about, going from a girl to a woman? And the dads always go, no, not happening. And the moms go, no, not yet. Why? I'm like, well, I think that's what's going on. And so we start having that talk about, what that looks like. And believe it or not, there are some, um, you know, young women out there that just have not had that talk by their parents. And so I do think, for you all as future providers, if this is a uh, circumstance you come across, like working with youth, working with teens, working with family stuff, that, you just encourage the parents, like, hey, this is a good time to have that talk. Um, Obviously, schools and providers, and there's a lot of information out there to help as well. I personally think it's best coming from the parents, but they don't oftentimes either have the education or the knowledge, or maybe it's too embarrassing for them, right? So it's okay to visit with them to try to move this in as healthy a direction as possible. But that does happen, and it is kind of funny because the dads always respond the same and the moms always respond the same. The dads don't want their little girls to grow up, and the moms are like, what? No, not yet. I guess it's time to have that talk, right? Okay. So, all right. So as mentioned a minute ago, the anterior pituitary releases the follicle stimulating hormone and the luteinizing hormone. Okay. And the follicle stimulating hormone is designed to mature the follicles, thus the word follicle stimulating. And the luteinizing hormone helps to stimulate ovulation. Okay. Estrogen, okay, does help maintain the growth and function of the endometrium. Okay, the progesterone, it's primary responsible for the functional layer growth after ovulation, increases blood vessel distribution, uterine gland size, and nutrient production. Okay, this is why too much estrogen and not enough progesterone can lead to some issues because of what progesterone does. Okay, so it helps with that functional layer growth, increasing in size, um, blood vessel distribution. You need lots of blood, lots of, because blood brings all sorts of good things to tissue, right? So oxygen, nutrients, also gets rid of the byproduct. Okay. Okay. So um, let's see, what time is it? All right. Actually, let's go ahead and take a 15-minute break. Okay. And we'll come back. We'll pick up right here. All right. I'll see y'all in 15. Okay. Um, so here you're seeing the different some different phases. Okay. So follicular phase is also known as the pre-ovulatory phase. Okay, also known as the proliferative. Okay, the proliferative phase. So this is where the follicles mature. Okay, so in this phase you have the follicles that mature. All right, around day 14, the egg is released, so that's ovulation. And then day 14, 15 to day 28, that is the luteal phase. Okay, which is considered the later phase of the cycle. Okay, and this is where the corpus luteum, the beginning formation of the corpus luteum. Okay, in this phase, either ends in pregnancy or luteolysis. Okay, gonadotropins, or any hormones secreted by the pituitary that stimulates gonadal activity. Okay, so it encompasses a bunch of different hormones. So those are gonadotropins. Okay, it shows you during the day 1 to day 27, 28, what happens with follicle stimulating hormone, and then what happens with luteinizing hormone. So when people come in from the fertility clinics with different labs, because there are changes in labs depending on what hormone you're looking for, depending on the day, there's often many different days, different labs, different tests, different hormones that are done. Okay, so it can be tricky, right? So once you get into your blood chemistry stuff, you don't necessarily just want to order labs just to order them. You want to be more strategic on what day so you can get an accurate timing, depending if it's day 1, somewhere around day 14, and then back to day 28. Okay. Okay, with estrogen and progesterone, okay, you can kind of see this is roughly split in half here. Okay, you have the estrogen part and the progesterone part. All right, estrogen helps part of regulating the menstrual cycle by controlling the growth of the uterine lining during the first part, as you can see here, like day 1 through 14, during the first part of the cycle. Okay, if the egg is not fertilized, estrogen levels will decrease. Okay, so they decrease. And then progesterone kicks in. And the progesterone is there to prepare the endometrium for potential pregnancy. So progesterone kind of assumes where, fertilized egg pregnancy stuff is going to take place. So it just prepares for that by increasing its level on the back half of the cycle. Okay. So it triggers the lining to thicken. That's where we want the 6 millimeters to 14 millimeters is our target range. Also, because progesterone helps do this, if there's too much estrogen and not enough progesterone, then you're really not going to get much of the thickening of the lining. Okay. So we actually will issue progesterone. So we do a topical cream. And then down the road, we'll do some. So we don't do estrogen blockers per se from medication. What we try to do is switch over the Zen estrogens to more functional estrogens and then increase progesterone levels. Okay. So vagina translated means sheath. Okay, it does extend from uterine down. Okay, it does have its own mucosal lining. So a stratified squamous epithelium. So stratified meaning multiple layers. So back in histology, your simple is one cell layer thin, and then stratified, and the way I talk to my students about it is the laying bricks analogy. So the more bricks you lay, right, and this can just go on and on and on with your layers. Okay, so one cell layer thin is function is for diffusion, secretion, absorption. Okay, once you get into your stratified or the thicker layers, it's more for abrasion resistance and protection. And I use my motorcycle analogy where if you're riding a motorcycle, some people wear like t-shirt and shorts and flip-flops, no helmet. So that's a very thin layer, not abrasion resistant. Okay. So if you wear your leather jacket, your armor, your helmet, that's a thick layer for abrasion resistance. Okay. So histology stuff, thin tissue, secretion, absorption, diffusion, and then your stratified or thicker layers, abrasion and protection resistance. Okay, and you can see the stratified layers there, stratified squamous. Okay, you've got your squamous cell, cuboidal, columnar. Okay. Um, the glands of Bartholin, they do release um, a lubricating type fluid. Okay, now sometimes these glands can get clogged, okay, creating, um, almost an inflamed follicle type thing, so they can be tender. Okay, oftentimes that can do with hygiene. Now, every once in a while, I have to visit with that with my patients. Usually, what brings it up is complaining of painful urination. Okay, so in my office, we can do a UA right then and there and look for things. Now, once I suspect, there's some sort of an infection or some other issue, I refer out for that stuff. Okay, and then I usually write a list based on their symptoms, their history, things they share, and that's one of them, to have OBGYN, or at least you tell your patient this is what they should look for, right? So I do think knowledge is power, and if you can just share things with your patients, like in my case, have them. These are possibilities. Look for this. Look for this. Look for this. Could be UTI. Could be kidney. It could be something else. At least so that they can understand like what's going on. I also think it helps with compliance. So as soon as you refer somebody out, they may or may not go. And so I've just learned over the years that the more you can educate them on things, the more the more likely they will go. Um, Another one is a bone density scan. I order those quite a bit. I've got senior women that come in, and I ask, when's the last time you've had a bone density scan? And most of them, like 95% of them, say never. I'm like, okay. So then, instead of just writing the order and sending them out, write the order and explain why. What can happen with brittle bones? What can happen to your hip if it fractures just by simply taking a step? And this is also something we can improve some of the strengths to your bone if it is starting to weaken, so let's catch it now. Now their attention's different, right? They look at you a little different. They take it more seriously. Okay. So this is certainly something for the OBGYN or, the pelvic exam practitioners, but I do like writing out things for them so that they can be a little bit more educated. And I always encourage them, look, just dive in. There's tons of stuff online, take a look. Um, let's see. Okay, mammary glands found in the breast. Okay, functions to produce and secrete milk, uh, which starts to occur during pregnancy. Prolactin is released along with oxytocin that helps with milk letdown and some other hormones. It is a complex mixture of proteins, fats, and sugar for nutrition to the infants. Okay, you'll also find colostrum, which is a really good immune part that usually occurs only within the first couple days or so of after the child is born uh, with breastfeeding. Okay, so one thing I do encourage um, moms to be is to at least get the child the colostrum, because some women don't want to breastfeed, some women do. I think that's a personal choice at the end of the day. So whatever they decide, at the very, very least, you at least want to get that colostrum into the child. Okay. So um, the let's see. So you have the nipple part, okay, the areolar part. Um, and also, let's see. Keep in mind another thing is, I think we talked about this a while back. Poorly fitting bras, okay, that are too tight. So during all the non-pregnant times, you want to make sure that is also a properly fitting bra so that you're not inhibiting lymphatic drainage. Okay, because one issue in our culture is breast cancer and fibroids found in the breast and things like that for women. Um, and then one thing that does contribute to that is poorly fitting bras that kink the tubes that do not allow adequate drainage of um, the lymph tissue, the lymph fluid. Okay, and then during pregnancy, uh, this is going to be enhanced because typically the glands and everything enlarge. So you also at that time want a properly fitting bra as well, so you don't inhibit the different tubes and different glands. Okay, that will also help prevent mastitis. Okay, which is very painful if that happens. Okay, let's go to the male reproductive. Okay, um, so for males, here's the lateral view. All right, so we have the urinary bladder, okay, and the infamous prostate gland, which can be a big risk factor for men as they age. The main thing being prostatitis or some form of inflammation of the prostate and or prostate cancer. Okay, and overall, that is an area that's relatively ideologic, which means we don't really know, but there are some ideas. Functional medicine does tend to favor the side of nutritional deficiencies and oversitting throughout a lifetime. Okay, so another way of saying that is lack of exercise and activity and too much sitting and poor nutrition. Okay, can lead to prostatitis. So we do what you can. We do what we can to prevent. But as you can see, because the urinary bladder sits superior to it, and you have the urethra that travels through the prostate, that's why men can have difficulty with urination or getting the flow started. Also, uh, the seminal vesicle is located above the prostate, and it also has some tubes that have to travel through it as well. Okay, so prostate issues can lead to erectile problems, or seminal problems because of that. Okay, so then you have the urethra, and also catheterizing, men versus women. Obviously, there's going to be a little difference. So those of you who will be doing that one day, they'll teach you it's a matter of feel, where you can feel the resistance from the tube, whether the urethra in a female that's relatively short versus the urethra in a male that's a little bit longer, to get that cath up into the urinary bladder area. Okay, primary sex organs are the testes. Okay, that would be uh, located there in the scrotum. Okay, you also have the ductus deferens that goes from the seminal vesicle, okay, and communicates with the testes. Um, let's see. So clinically for men, there's some things that on the PT functional medicine side that we can consider. Okay, one of them is the cremasteric muscle. Okay, so this is a muscle that does wrap around the testes and works its way up into the inguinal area. So this muscle allows for the testes to either distend or contract based on temperature, right? So the sperm is sensitive to temperature changes. They don't want to be too hot or too cold. So if things are really warm, the cremasteric muscle relaxes and the scrotum will kind of distend. And if things are cold, the muscle contracts and the muscle will move the scrotum and the testes closer to the body to stay warm or to try to keep the sperm warm. Okay. But sometimes this can spasm, right? The cremasteric muscle can spasm, and that hurts. Okay. So, as you can imagine, what that would feel like if that muscle just really start biting down and squeezing pretty hard. One area where I see this often is post vasectomy. Okay, so surgical procedure, and it's basically kinking a tube on purpose so that the semen and sperm don't mix. And but a side effect can be spasming of the cremasteric muscle. Now, usually by the time I get a male that has this, they went into either the hospital or back to the surgeon first because it feels like they have cancer. That's usually the card they pull. Like, I think I have cancer, in my testes because of the way it feels. So they do all this exam stuff and images, and like, well, we don't see anything. And, so if they don't really see anything, they're like, well, there's really nothing we can do. They might give them pain meds or muscle relaxers or something, but they really don't do anything. Then I'll get them, and then we evaluate, and you can tell that cremasteric muscle is just pissed. It's not letting up. Okay. And of course, my favorite is doing the dry needling, putting needles to, which releases it almost instantly. The spasm almost instantly goes away. Okay, you can also do trigger point work, and there's some instrument work you can do with different machines that are designed to get in there and loosen that up. Okay, then there's homework for them to prevent the spasming from coming back. And usually within a week or two or three, we get it under control and things go away. Okay, they're pretty good. Okay, the scrotum is skin covering sac that provides protection for the testes. Okay, so here's what that would look like in a actual cadaver, human cadaver. Okay, scrotum and testes. Okay, and if you're thinking, wow, that sounds brutal to go in there with a needle, it's actually not bad. I mean, we're talking about a 40 gauge needle, so it's super skinny. It's almost as thick as a human hair. Um, you do feel a little pinch, but it's not bad. Okay, the spermatocord originates in the inguinal canal. Okay, and it does have an artery, the testicular artery. Okay, and this is a very important area because of blood flow. Okay, so I'm a big fan of circulation. Tissue and cells love oxygen, they love nutrients. Deprivation of that can cause problems. So, you know, similar to the poorly fitting bra, we'll talk about poorly fitting, boxer briefs, um, anything in that family, type of underwear where you just don't want it too tight, okay, because that cuts off circulation and can lead to problems. Okay, there's certain stretches and exercises that can be done. There are some now. This next part, I'm going to say I don't do this. I don't specialize in this, but it is a thing. There are perennial needling techniques that can be done for female and male incontinence, erectile dysfunction, pelvic floor weakness. Okay, so that perennial area with needling, and actually it's needling and electricity. So they hook them up to the needles up to electrodes. Sounds miserable, okay, but apparently it's not at all bad. I've talked to many people that have had it done. I know some practitioners that practice this, and it just sounds like the worst thing ever. But apparently, it's really not that bad. And it does help. It helps quite a bit for either different forms of incontinence, erectile dysfunction, pelvic floor weakness, and so on. Okay. And like any medical procedure, it's not 100% guaranteed, but it does help tremendously. In fact, it's growing. So a lot of urologists and other, repro docs and gynecologists and all that are starting to refer to this technique because of the success. Okay, and then you don't worry about side effects of medication and all that kind of thing. So it's definitely growing. And every time I go to my dry needling seminars, and advanced training and stuff, they're always trying to recruit people to do this because nobody wants to do it. Stick needles in the perineal area in people. Okay. Now, granted, there's people that will, but it's a very unique specialty, and they're just trying to get more people because it's growing. Um, okay, the function of the testes include sperm, to help with sperm production and the secretion of the androgens such as testosterone. Okay, so low T is kind of the expression. Okay, and what that means is low testosterone. This is something I do test for often in both men and women. And so, yes, it is a thing in women to have low testosterone, and it's certainly a thing in men to have it as well. The other thing in men is they can also end up producing too much estrogens for the xenestrogen reasons and other estrogen blocker reasons that we've talked about for women. So men are at risk for getting some side effects as well from that. It also hurts the DHEA cycle. So DHEA is the precursor to testosterone. So when it's given the proper hormone signal, it's either going to create testosterone or estrogen. And sometimes in men, it starts to favor more the estrogen route. So they're consuming foods that are pro-estrogen, okay, like soy and other things, plus what's going on internally can create way too much estrogen and not enough testosterone. So we want to evaluate this through labs. Okay. And low T can lead to, you know, low libido, can lead to uh, just feeling tired all the time, changes in sleep wake cycles, fatigue, not responding well to exercise, erectile dysfunction, and so forth. And both genders can actually experience this as well. Okay, it just tends to hit men harder than women with that. So there are things we can do naturally to boost testosterone. Okay, so we look for serum bound testosterone plus testosterone, and that's another common mistake that is made, and I'll explain that in a second. So you have serum bound testosterone and then just testosterone, right? In other words, testosterone binds to a protein and floats around the body and is released when necessary. Sometimes that binding isn't released, okay? So that's why you have to look for that as well, because what will happen is they'll just test for testosterone. And if the number comes back low, then the knee jerk reaction is to prescribe a certain level of hormone replacement testosterone, not taking into account the serum bound. Okay, so you want to make sure that you get both those labs as well. And then at that point, it's up to you if you want to do hormone replacement, which would either be a testosterone capsule that they make an incision in your glute muscle, so basically your butt cheek. Okay, stick it in, stitch you up, and it lasts about 6 months or so, slowly dissolves over time. Or you can do shots. Now, I personally recommend shots to my patients, but it's still up to you. Uh, the capsule, which is the incision, dissolves over 6 months, or the shots, simply because of the risk of infection from constantly being. I mean, if you think about that, I don't want someone to open me up every 6 months to put a capsule in. You know, you're sore for a while, you got stitches. It's, some people don't care. That's just my thing. I wouldn't want that. And so I just, kind of talk about the pros and cons. Same for women. I have patients come in and I do a lot of gluteus maximus, gluteus minimus hip work, okay, greater trochanter. So kind of that whole posterior pelvis area. And this is very hands-on, right? So they'll come in and like, hey, I just got my incision and I don't want you messing with that area because it's sore. I have stitches, which I understand. Like, of course, we're not going to mess with that spot if you have a fresh incision. And and I get that a lot, right? So people come in to tell me, um, and others will come in just from a series of shots and they're just simply sore from a needle injection. Okay, really not a big deal. And we can certainly do some work on them. Uh, so, um, personally speaking, I'm still on the fence about hormone replacement because of the side effects. But as time and technology and advancements in medication and stuff get better, I actually do think it's a really good thing. And it can help a lot of people. In the old days, when, um, certain hormone replacements just, it was more synthetic and, just the way it was formulated, it was like, eh. But today we've got some really good stuff out there, and it's definitely a growing profession. It's a growing thing with the aging body. As people age, like, what do you do? Okay, do you do hormone replacement? Do you not? Um, so a personal decision. I do have patients that we talk about this with, and because I've seen it for myself, just taking care of people over the years, it does seem to really, really help. Okay. So, not something you really have to be worried about till maybe as early as age 40s. Okay. Certainly age 50s and up, just because as time goes by, things naturally decline, hormone changes and stuff like that can happen. I also take care of some owners to, like aesthetic type clinics, where they do facials and laser treatments on skin, tattoo removals, anti-aging, breast augmentation stuff, tummy tucks, um, and just anti-aging stuff, right? So part of anti-aging is hormone replacement. So, I hear from the owners that practice these things and they order these things and stay up with the latest in technologies. And this is what they tell me. They're like, gosh, you go to these seminars, like these anti-aging seminars, and they're almost like, it's almost like you don't have to age. There's so many things out there that people can do to drastically slow down the aging process. It's crazy. But the only problem with that is it's very expensive. Some of the equipment is very expensive, and then treatments are very expensive. So for a lot of people, it's just not feasible. Okay, even though the technology is there, and I think as time goes by, some of that cost will go down. It usually does, and we'll see. Okay, it's not really a specialty of mine. I'm not really into augmenting the body through anti-aging. I'm more into aging into a healthy body because of healthy diet and lifestyle. Okay, so that's more my thing. Obviously, aging is inevitable, which we'll actually talk about a little bit of that once we get to part 3 here. But I think everybody can always practice a healthy, balanced lifestyle. Okay, and that alone, lower stress, good antioxidants, basics of diet and exercise, and so forth, can, not spending too much time in the sun. Okay, like that's definitely a thing with skin. I know I didn't have you all for ANP1 when we got into skin, but I do talk about that with the amount of sun per day and then over a lifetime that is kind of recommended, so to speak. And what we find is, usually in youth, is there's overexposure, right? So for 30 years, overexposure to the sun, and then the latter part of people's lives, and they start dealing with, different sunspots and skin cancers and whatever, because of what the sun can do to you. But at the same time, you need to be in the sun. Okay, so like, where's that balance? Like, how do you, where's that happy medium to enjoy the sun, but not too much and not too little? Okay, so that'd be another part of anti-aging is um, certain limitations to protecting yourself from the sun. Not 100%, but you also don't want to be in the sun, 10 hours a day. Um, I remember back in the spring break days, in Florida, gosh, people, man, the stuff they put in baby oil on and, saying things, I wish I had a magnifying glass I could just put right just to, get as much rays as I can. When you're 18, stuff you do, tanning beds and whatever. But there are healthy doses of that stuff. It's just part of, being careful, treating your skin well, and treating the inside parts of you best you can to age as gracefully as you can. Okay, so some anatomy, inside anatomy of the testes. Okay, so here's the ductus deferens. The epididymis. Okay, and then once we get inside of the lobule here, okay, you can see the germ cells where the sperm is made. Okay, of course, they need the presence of testosterone to help do that. All right, and then so the ductus deferens comes in, okay, turns into the epididymis, which then turns into the seminiferous tubules. Okay, the interstitial cells is a site of where the androgen, so testosterone, is made. Okay, the interstitial cells. Okay, spermatogenesis, or the creation or formation of sperm. Okay, so in the first part, the diploid cells, so the germ cells, called the spermatogoniums, that's where they come from through the mitotic division, then eventually go into their division into the meiosis phase. Okay, so the 23 chromosomes are produced during this time, during the meiosis 1. Okay, and then the meiosis 2, you get the secondary spermatocytes and the spermatids. Okay, then in the fourth phase, you get the addition of the flagella. Okay, and the mitochondrion, which is the energy that helps these little things swim. Okay. Also, we issue a coenzyme Q10. Okay, so CoQ10, which heavily influences the mitochondria. So going back to the fertility specialist, usually both the husband and wife are checked. Okay, so they check her for all the different hormones, estrogen, progesterone, luteinizing hormone, all that. If the fallopian tube is open, sometimes they're clogged, sometimes there's too much fluid, uterine lining thickness, and so on. Okay, lots and lots of stuff that they test. And in men, they'll test for similar, with testosterone, estrogen, progesterone stuff, luteinizing hormone, follicle stimulating hormone, that are also released in men to help with spermatogenesis, and also sperm count and sperm motility. Okay, and then if they do have slow motility, this can help tremendously. Okay, CoQ10. Okay, because that does go to the mitochondria, that helps speed up the energy. Okay, so there's the head, the mid piece where the mitochondria is, and then the tail, or the flagellum. Okay. Okay, your androgen hormones are estrogen, progesterone, testosterone. Okay, so androgens do help prevent oversecretion of gonadal-releasing hormone, okay, which is hypothalamus. Whoops. Hypothalamus can releases gonadotropic releasing hormone, which then releases your follicle stimulating hormones, luteinizing hormones. Okay. So as these are released and then men go to the testes to communicate, these also help produce secondary sex characteristics, okay, via testosterone. So deepening of voice and, pubic hair production, muscle mass, creation of sperm, and so on. Okay, from this one, just from an anatomy perspective, I'd like for you to know testes, the epididymis, the ductus deferens, okay, the seminal vesicle, okay, urinary bladder, the prostate or prostate gland, okay, and the urethra. Okay, there's two parts to the urethra. You have the prostate or prostatic urethra, and then the urethra. All right, so the blood engorging areas, corpora cavernosum, which is the more external part. Okay, and then the internal one is the corpus spongiosum. Okay, dilation of blood via NO, nitric oxide, helps with this. Okay, so on my end with working with fertility in men, we'll issue the nitric oxide, and those are specially formulated to allow for NO to be produced, which is a vasodilator. Okay, the best over-the-counter is by a company called FXN. It's pronounced Phoenix. Okay, don't ask me why, but you know, it's Phoenix, but they spell it FXN. And it's called L-arginine. Okay, L-arginine. And there's two of them. There's L-arginine, and then there's L-arginine drive. Okay, the drive is more potent. Do not recommend this for 18 to 22-year-olds. Okay, they'll probably have the equivalent of a side effect from Viagra, if you know what I mean. So, so if you're, you know, late teens, early 20s, I would suggest you be very careful taking an NO2 or an NO supplement, something like Phoenix L-arginine. Okay, this stuff was developed by years ago, developed, and they got your Viagra from this. Originally, it was designed to help with cardiovascular heart disease for vasodilation in the heart blood vessels. Okay, the guy that developed it, his name is Louis Agnero, started out to help the heart, but ended up kind of accidentally, for lack of a better term, discovering this can also help with ED, okay, erectile dysfunction stuff. So there's prescription form of this, and then there's over-the-counter. Okay. So it's a vasodilator, and that would also be a function of the cavernosum and the spongiosum. Okay, the epididymis stores the sperm. Okay, also serves in the maturation process of the sperm. Okay, after the sperm leaves the epididymis, it will enter the ductus deferens, also known as the vas deferens. This is where the vasectomy comes in. Okay, the vasectomy. So they clamp. From my understanding, there's two different versions. There's more of a permanent version and more of a reversible version. Okay, the reversible version is a type of a clamp, and the non-reversible version is an actual cut and separate. Right, so you have a tube, cut, and then that turns the tube into two different parts. right? And then you close off the ends so things cannot go from point A to point B at that point. Okay. A personal decision at the end of the day. Um, you know, some I've had some patients come in, mostly because of the cremasteric muscle issue, and because post vasectomy, and they open up about it. A very common story, and at least in my experience, I'd say 99% of the time is we've already got 3 kids and we're just done. It's like, okay. And some people super young, like, I don't want kids, and then they get it done like when they're 20. It's like, okay. So either way, at the end of the day, it's a personal decision, um, what you want to do. I've even had couples in front of me argue because the husband argues he wants the wife to get the tubes tied, and she argues um, she wants him to get the vasectomy, and I'm stuck in the middle. I'm like, oh my goodness. And they're not there for that, necessarily. It's just stuff that sometimes comes out on the table as couples come in. And the reason I bring that up is the between the two, probably the safer one, if that's even a thing to say here, would be the vasectomy part. It's less invasive, okay, more invasive for women. And so usually when I say that, the wife always goes, "See, I win," and he's like, "Dude, you're supposed to have my back." I'm like, "Look, that's just the way it is. It's which one's better physiologically between the two. Go for the vasectomy, man." All right. I guess I drew the short straw, but same thing. End of the day, it's a you know personal decision that people need to make to figure out where to go from here. I also the other options are intrauterine devices and or birth control. And some women, they're like, they just don't want to be on it anymore. They've been on it for forever, and they can tell some of the side effects are starting to surface. So these are some really deep and sometimes painful conversations that people need to have. And there are very kind ways of talking about it. Um, in my experience, the best way is just to talk about it strictly through physiology. You know, just here's the tissue, here's what's going on, here's what can happen in the body. And then, you pick your best choice from that. Um, so knowledge is power. Lots of research, talking to different practitioners, talking to different people with experience, talking with each other, and then figuring out where to go from there. And no, I'm not sitting here advocating, get all this stuff done. I am just saying you're going to come across patients in this reproductive realm that it is all over the place. Okay. They're going to be dealing with cancers and tumors and erectile dysfunction and incontinent stuff and, birth control issues and just, pain, tightness, cysts, everything, right? It's just can happen to people. And so depending on the area of healthcare you're going in is going to depend on your level of influence to your patients. And, even as nurses, you can still positively influence people by encouraging them. Knowledge is power, sharing with them a few things. Okay. Also, as future nurses, your friends and family automatically think you know everything. You're probably already experiencing that. Oh, I'm in nursing school. Oh, really? That means you know everything. And then they run all these different conditions by you. Okay. I'm sure you all have gotten that by now. It's just a thing. And here's the best part. Friends, close friends and family ask you these, healthcare questions because they think you absolutely know everything and you have the magic wand and everything's going to get fixed. And then you actually will advise them. You're like, I actually know about that. I've actually seen this done. I actually have experience in that area. And you'll tell them exactly what to do. And here's the best part. They don't do anything. You're like, wait a minute. Well, then why did you even ask? Ever notice that? Usually from close friends and family, ask you all sorts of stuff and then do nothing. It's like, my goodness.
After a vasectomy, what are the chances of the pathways growing back?
Well, that's the difference between the permanent version and the temporary, for lack of a better term, temporary version. So apparently the temporary one's pretty good. Um, last I heard, I mean, it was like a 90% chance of success to reverse that. Um, but of course, the permanent one is permanent, and I don't think there's any chance of getting that back.
Can they grow back just naturally?
Well, it's
I'm just curious because one of my friends, his dad got a vasectomy 26 years ago, and then 26 years later, he just had a kid again.
oh, I see what you mean. Okay. Well, that's why they tell you it's 99.99% effective. I'm not kidding. True story here. I have a a, a a a patient. She's a yoga instructor. She's everything. Gosh, CrossFit, yoga, cycling, whatever. I mean, this she. I mean, I seriously think she puts 7,000 miles on her body a day. But because of that, she's always broken down and muscle pain, joint pain. So she comes in. Here's what happened. He had a vasectomy. She was on birth control, and they got pregnant. How about those odds? They remember they came in one day and they like, guess what? We are pregnant. And you're like, what? And then that's where I stole the idea from. They're like, that's why they tell you it's 99.999% effective because there's always that 0.001% chance. So it can happen. Well, the reversible is a no cut method. Now, if this was 26 years ago, back then, technology was, or I should say, procedures were different. Today they're much better, especially the reversible stuff is much better. So they call it a no cut method, which is the reversible one. My guess is back then, I guess you'd have to ask this guy. They took the tube, cut it, but then clamped it instead of cauterized it, which means yes, it can grow back. But here's the other thing to consider is if you have one tube here, okay, and another tube there, and and these are super tiny cells, right? The sperm cells, and you've got the sperm production, right? And so they're coming through. They're probably leaking through and then just going into the space, but then some might actually get into the more distal tube and then work their way in, the more distal ductus deferens, and then work their way in, and then eventually mix with the semen, because those come from two different areas, right? The semen comes from point A, the sperm comes from point B. Okay, so semen comes in, sperm comes, and then they mix, and the sperm is ejected with the semen, right? So if you have a vasectomy, you still get an ejaculation of just semen, but no sperm cells are supposed to be present because that's the area they cut off. So again, just my guess is it was probably something in this family where there was an opening in both tubes, even if it was a tiny opening, and you're still producing sperm, you're still producing semen. So this would be the sperm side. This would be the semen side. And, sperm is just not matching up with the semen. And in that case, it probably did. Okay. Again, just a guess um, that happened. Yeah, 26 years ago. Yeah, you'd have to, gosh, that would be interesting to talk to that person and then have them talk to the surgeon just to see what the actual technique they used back then was.
He was very surprised because his girlfriend was on birth control, and then he had a vasectomy, so they thought they could have kids.
So similar story, huh? Where they both,
Yep.
wow.
So
Wow.
they so
So how's the child now?
as far as I know, the child's doing good. My friend was just surprised that he has a brother that's 25 years younger than him.
Oh, wow. Wow. Yeah. So, um, I'm pretty sure that's why they do this 99.9%, 99% of their, because there's always that super rare chance. Okay, so as the ductus deferens approaches the prostate gland, it enlarges to form the ampulla, and then the ampulla unites with the proximal portion of the seminal vesicle to form the ejaculatory duct. Okay, and so I was trying to draw earlier, that's where the two come together, formed by the uniting of the ductus deferens and the seminal vesicle. Okay. Well, we looked at the urethra earlier. And okay, talked about prostate stuff earlier. So just another picture of it there. Okay, so saw palmetto seems to be a supplement that can help reduce prostatitis. Okay, I recommend iodine in the form potassium iodine, vitamin D, and this is at the very least, and then the saw palmetto. Okay, and then usually your more advanced supplements add a lot of synergistic ingredients because part of the electron transport chain that actually gets supplements or nutrients, I should say, into a cell. Okay, not all supplements are created equal. And what that means is some are synthetic and they just lack the proper synergistic ingredients to actually allow for the the different nutrients that you're taking, the supplements, to actually get into the cells and do their job. So typically what you want to look for is they are biologically active, okay, which means they're naturally derived, not synthetic. So biologically active, and they do follow the active part of the electron transport chain, which means the body will recognize it as a macro or micronutrient and get it into the cell to actually utilize it as for its function. Okay. Same with that CoQ10. Not all CoQ10 is made the same. Some of them are made just the way that they're made. They don't really get into the body. So a lot of that is expelled, because that's how food and diet and hydration and nutrients and supplements work, right? Like right now, if you were to drink like 50 ounces of water right now, probably in 15, 20 minutes, you'll be peeing. Okay. Because it's just too much water. And your body's like, no problem. I can actually get rid of the excess. Right. Same with proteins. Ideally, and this is in a healthy, active person, the body can really only utilize about 50 grams of protein, 50 grams of protein in one setting. So if you eat 100 grams of protein, first of all, you're overloading your kidneys. That's not good. You're going to change viscosity of blood, which it gets thicker. Okay. You might risk proteinuria and other protein metabolism problems because it was too much protein in one setting. So in other words, the human body can only handle so much food and nutrients and all that kind of stuff in one sitting. Okay. So it's not so much that mega dosing is always good. It's just taking the right amount and of the food or nutrients or supplement stuff that you're taking, its ability to actually be utilized and not wasted. Okay. And that's where you do get into differences in food quality and nutrition quality and supplement quality. Okay. So just on one more tangent on this, if you look at certain fast food meats, they are not 100% ground beef. It's usually a mixture of a lot of different fillers that makes it look like a hamburger patty, but it's not. Okay. And then they add a bunch of additives and preservatives and other chemicals and so forth. They even add, and yes, this is true, they do add addictive different spices and chemical stuff to it on purpose to make your body crave it. You want to go back for more. Okay. That is a thing. And so, in other words, it's not quality. It's not a quality protein. Okay. It's not a quality piece of food that you're eating. So, and that's true for everything, quality of water, quality of food. Um, and that's why, in simple terms, you just want to try to eat clean, locally grown best you can. Okay. Stay away from pro inflammatory and artificial foods and take certain supplements. All right. Because of the whole COVID thing right now, lately things have been immune boosting. So, at the very least, because I know cost is an issue for a lot of people, for immune boosting, the very least would be vitamin D3, um, vitamin C, and in the fancy stuff, it's bioimmunozyme forte. Okay. So even from that, at the very, very least, would be just the bioimmunozyme forte and the vitamin D3. Okay, and these are really good immune boosting techniques. Now, there's other things you can take that people can take that enhance your body's ability to fight viruses, enhance your lungs' ability to fight things off, and so on. Okay, so transfer factors is another one. Those have to do with your T cells and your B cells, different ways to get your white blood cells more active in a good way. So obviously really cool things out there, but then at that point you risk cost. It can get expensive. Okay, so for prostate health, saw palmetto is one with its associated synergistic ingredients to help get things into the cell, plus the iodine, plus the vitamin D. And ideally, men want to start this young. The younger, the better. Okay. Um, if you're 60 with an inflamed prostate, does it hurt to start then? No, but that's when people do, right? When ideally they should have started that, 30, 40 years ago. Okay. So again, trying to age into a healthy body. And unfortunately, it's not really a thing that's taught very much or talked about much in our culture because we are a more symptom-based culture, which means you don't do anything unless you have problems. Okay, once you have problems, then do something. All right. Now, certainly we have the technology to try to help people with that. And, you all will see that, especially if you're working in hospitals and ERs and stuff like that. I mean, and outside of trauma, okay, you're going to see this because trauma doesn't count for this stuff. That's a different animal to deal with. So, unfortunately, just a lot of health problems. Okay, we'll talk more about that in pathophys. But your formula for um, adverse health is a complicated combination of genetics, epigenetics, environmental, diet, and lifestyle stuff. Okay, and that's kind of it: genetics, epigenetics, environmental, diet, and lifestyle. Okay, so anything from an example would be genetic type 1 diabetes. Okay, fine, they have it, nothing they can do, there it is. Now you throw in environmental, um, just things that they've done to themselves in a good way or a bad way throughout a lifetime. And unfortunately, if it's unhealthy choices over a period of decades, then they're going to be seeing you in the hospital with all sorts of issues. Okay. And that's just one example. And there are, of course, many examples. So, my point is, you basically have two sides to healthcare. One side is preventative care, and the other side is like symptomatic care. Once you have it, we have technologies and procedures and things to help you. And by the way, some of that stuff is cool. Okay. I've got a pretty close friend that works at ICU cardio, and good grief, some of the stuff that they do to help people post-op, and they have all these different issues. It's just, honestly, it's amazing, the stuff that they have. Now, do I want a patient to go through that? No, but if you do, we've got some cool, skilled people to help you with that. Okay. So prostate issues, you know, unfortunately, that is a male thing, very common, as we get older. And I encourage, to start as young as you can with healthy prostate stuff. And that would be nutrition, um, try to avoid prolonged sitting over your lifetime. Okay. And basics of exercise, because you want the circulation, you want the movement. Okay, the prostate gland produces a substance. Okay, and also, guys, just hang in there. Okay, once we're done with this, then we'll take a break. Okay, almost done here. Okay, produces substance that's secreted into the prostate urethra. Okay, the prostate secretions are acidic. Okay, so they contain the mucin, citric acid, and these are nutrients for the sperm. There's also some antibacterial components to it. The test that you can do is the PSA test. Okay, prostate-specific antigen. Okay, it's an enzyme that helps liquefy the semen. The higher the score, so if you do a PSA lab, the higher the score, the more not good that is. Okay, that was proper English there. The more not good that is. Okay, so people come with a score of 7 or 9 or whatever. These are just red flags that you might be dealing with prostate cancer. All right, so I do recommend, these days I recommend getting PSA tests once you turn 40. Okay, it's just a lab. Knowledge is power. I'm a big fan of studies. I like labs, x-rays, MRIs, ultrasounds, all that stuff. Okay, because they reveal valuable information. Early diagnosis can lead to a better prognosis. So just getting a full physical blood panel, your lipids, thyroid, PSA, your diabetic markers, inflammatory markers, liver enzymes, CBCs, metabolic, all that stuff. It's great. It's basically like 6 vials of blood, and you send it out and you get the results. Very easy. Okay. Then based on the findings, should there be any positive findings, then you can go down that route of intervening and helping people. If it's mildly out of range, a lot of naturopathic processes can bring them back into range. If it's what I call a red flag, then I send them out because you're flirting with something that could be a really big fire that needs to be put out. So send them to that appropriate person, and then maybe later down the road co-manage. Okay, like right now, just got some labs back, and this person is flirting with type 2 diabetes, mid 40s, overweight, and mother passed away from kidney cancer, and father is also flirting with kidney problems, currently speaking. Okay, and so chances for the offspring to have some issues going on are very high. And there's your genetic factor, and now we're including environmental factor. And we've already gotten into the history, with this person, and just, as far as diet and lifestyle stuff, it's like there's room for improvement. Okay. But the good news is, mid 40s, so kind of catching everything somewhat early. So a wonderful chance to turn over a new leaf. Otherwise, in 10 or 15 years, they're going to come see you at the hospital for some serious issues. Okay. Okay, the bulbar urethral glands is what releases the mucin. Okay, also known as Cowper's glands. Okay, right there. Okay, you have the semen, comes from different glands in the body. Okay, once it is released, it's called ejaculate. Okay, and then semen can hold anywhere from 200 to 500 million different sperm. This is why in the fertility things they do a sperm count to look for count and motility. Okay, so the external genitalia would be considered the penis and the scrotum. Okay, the body is the shaft. The tip of the penis is the glans. Okay, you might also read in certain books prepuce. Okay, mentioned this earlier with the cavernosa and the spongiosum areas that help with erection. So these are considered the erectile bodies. Has to do with blood flow and the nitric oxide. Okay, parasympathetics are responsible for the erection, and your sympathetic nervous system is responsible for the actual ejaculation component. Okay, so some of these fertility meetings that we have with, men, women, or the couples or whatever, that's one thing I will get into is the parasympathetics versus the sympathetics, rest and digest versus fight or flight. Okay. So, in other words, when you go to fertility specialists, that's one of the things that they get into is counseling stuff, or at least one of the things they offer. Because sometimes everything is fine, it's just mental, right? Um, so, I do think it is important to address the autonomic nervous system. I think dysautonomia is very, very common in our culture because what causes this is stress. Okay, so stress creates this thing called dysautonomia, which means there's confusion between the parasympathetics and the sympathetic nervous system. If your body is constantly in sympathetics, then it's not going to function very well in parasympathetics. Okay, and that's the part of your nervous system that does allow for erections. So sometimes it's just as simple as getting people to control their autonomic nervous system, getting it under control. Okay, on paper, very easy. Stay away from this stress. Just don't let it bother you. Slay those dragons and then be relaxed and calm. Have a good day. That sounds great, but then actually applying it, that's tough. That's tough to ask people just to simply not be stressed. It'd be wonderful. Just don't let it. Ever hear that? Well, don't let it bother you. It's like, well, good luck with that. Of course, it bothers me. And everybody's different. Some people, everything bothers them in life, and other people, only a few things bothers them in life. And there's everything in between. Everybody's different. Okay. So it's worth talking about to help fix, if you will, the dysautonomia. Okay. Let's see. All right, let's come back at 11:30, and I think we can knock out the other stuff by 12 noon, okay?
I have a question.